So thank you very much for this opportunity. I want to thank Dr. Buckstein, Mittelman, and Dr. Neimer for inviting me and for you to stay. Actually, I think this is a fantastic morning. I'm a little bit stressed because I think everything is so complex, actually, and it just seems to get worse in terms of its complexity the more knowledge we have. So I'm going to try to give you a little bit of an idea of maybe what's happening in patients with high-risk disease and perhaps ask more questions than answers. I have 15 minutes. This is a very aggressive agenda, so probably I will go very specific to some of these topics. But I think what we need to discuss or think about as a community is how we beat single-agent azacitidine. Dr. Sabon actually 10 minutes ago said something very important in terms of how we define this disease. I'm going to talk a little bit about something that I think is quite important, that is the development of these oral hypomethylating agents, a brief update on combinations, 2 sentences on targeted approaches, something that may be coming back, that this issue of AML-like therapy, and then perhaps talk a little bit about integration of transplant, and maybe some conclusions at the end. So this is basically what we need to beat. And we have not been able to do this actually the last 20 years. We have actually here Dr. Silverman, who put out the first seminal data in terms of the use of these drugs in myelodysplastic syndrome. This was followed by this really landmark study in our field, the 001 trial led by Pierre Fenot, that around, I guess, 13 years ago, put this drug in the map as the standard of care for a majority of patients with high-risk disease. And until today, we have not really been able to show anything that is better to this data. The first issue, actually, that is evolving is the definition of the disease. And Michael said something very important a few minutes ago, that is, what is this that we call high risk or low risk? I think he was referring at low risk disease in the CCUS talk. But if you look at this IPSS and the IPSSR and this IPSSM, okay, they are very nice. But actually, probably the most fundamental phenomenon that we saw with the IPSSM is in the bottom of the slide, that there is a shift from patients that we used to call lower risk disease to higher risk disease. And that's what he was saying. So these are patients that may have more benign characteristics. Maybe the karyotype is not that abnormal. Maybe the blasts are not that elevated. But then you look at the genomic level of this patient and has a high level of complexity, P53 mutation, or as we had discussed, let's say, more than 3 mutations, or patients with very poor risk alterations, ECH2, or at a very high VAF, that really are changing the biology of the disease. So we are shifting. Another question is, how do we incorporate these patients with quote-unquote traditional lower-risk disease into a high-risk paradigm? And that's why he was asking, should we transplant these people? I don't have the answer for this, but this is actually one of the most important things coming out of this IPSSM, that is we're going to be moving those patients from the left basically to the right. So it's going to be very interesting, in particular to when do we use a stem cell transplant. That is something that we have never used in lower risk disease. Why? Because the risk is too high. You have too much to lose if you have early death with that intervention. Now, people, we can be cynical and say, well, there's not been a lot of progress, or some of these drugs are maybe me toos, things like that. But the reality is that some of us in this room have been working on this area for 20 years now. And the first thing actually that our patients ask us is, when are these drugs, azacitidine, decitabine, going to be something that I can do at home, that I don't need to be coming to some clinic 5-7 days a month. So from the very beginning, actually, we wanted to develop these hypomethylating agents through an oral approach. And there are basically 2 approaches to this, although there's only 1 drug approved for myelodysplastic syndrome. So one actually is to combine the hypomethylating agent with a drug that inhibits cytidine deaminase. That is a key enzyme, basically, that is the rate-limiting step in terms of the absorption of these compounds. Prototypical compound is known as cedazuridine. And there are 2 drugs, actually, that use this approach. One is ASTX727. This is the oral decitabine cedazuridine. This is approved in the United States for patients with myelodysplastic syndrome. I am not sure if what I'm going to say is true, but apparently this is also now approved in Europe for acute myelogenous leukemia. At this ASH meeting, actually, is going to be the first presentation on a very interesting, I think, potentially very fundamental compound known as ASTX030. Actually, this is the azacitidine with cedazuridine. So the data we are going to be showing in one of the posters is that we are getting close to a drug that PK/PD-wise could be similar to the injectable azacitidine. If we can get this done, I think that's going to be a major breakthrough. There are other ways to do this, maybe combining this with tetrahydroline. Of course, we have the oral azacitidine, the CC486. This is actually unconjugated agent. This is approved for post-induction therapy AML. We've been working actually to revamp this drug also in lower risk myelodysplastic syndrome. These are not the same drugs. They have different PK/PD profiles. And as we've been mentioning early on, we probably will learn different subset of patients that may benefit or not from this. Going back to this cedazuridine story, this is basically the schema of this drug. So you have the decitabine, what you've been injecting for many years. And now basically you are combining it with this compound, cedazuridine, that is basically modulating, when you give the decitabine orally, the rate of absorption of this compound. And we designed a study known as the Transplant trial. This paper now finally is in press in Lancet Hematology, where we basically did, in my opinion, one of the most interesting randomized clinical trials, where we're randomizing at different schedules of this drug, focusing on the PK/PD profile of this compound. And you see there that this AUC is around 99%. Basically, this oral decitabine cedazuridine is pharmacologically identical to the IV drug. So that's nice. Then Dr. Savona, myself, started putting out some of the clinical data from this trial. So CR rate 22%. This is now a huge debate. What is the CR rate with ASA or with decitabine? Is it like 7%? Is it 30%? Nobody knows, but this is actually not a bad number. Then we started putting out the survival data, and actually it's not bad. You say, okay, that's interesting, but this study is really not designed for, ask this particular question of whether this drug is better or worse than your standard hypomethylating agents. But then at ASH last year, there was a really interesting presentation that we don't understand, and poses the question of, are these drugs actually the same drugs or not? So at the beginning, people said, well, Ascertain is a nice study, but it has a lot of low-risk patients. Actually, that was not the case. Indeed, over a third of the patients had high-risk molecular features like a p53 mutation. So we presented this data where we look at basically the impact of p53 mutation in the context of this particular trial. And then as you expect, if you're wild type in blue on the left, it's better in terms of survival. But if you look at the overall survival and the leukemia-free survival, it's actually double what we have shown for any single study in the past. This includes single-agent azacitidine, this includes the studies with the APR compound, and it actually includes the study with the anti-CD47 antibodies. Now, is this an artifact of just one study and we got lucky here, or is this something that somehow related to cedazuridine or maybe the pharmacology of this drug really has meaning? I think we really need to put a little bit more energy in understanding how these drugs work, particularly in this group of patients with poor risk molecular features. Now, the other thing that people in this, and I think many of us are in this room today, has been this issue of the doublets, right? I started my career combining these drugs with HDAC inhibitors, total epigenetic synergism. All of them fail. And then we went through this kind of litany of doublets with pevonidostat, with the APR-246, now with the magrolimab. Now, in the last three, this sabatolimab, venetoclax, and this retinoic acid, they are not yet negative. We don't know, so I don't know what's going to happen with them. Although we have seen some data with sabatolimab last year at the ASH meeting that makes a prediction of a positive study kind of low. So we'll see what happens with that. I think one of the problems of these studies actually comes from very simple observation, and we presented this at ASH a number of years ago. It's actually been updated soon with this drug that I disagree with. I don't know who said this drug. It was CIS. This drug has no activity. Actually, this is a wonderful hypomethylating agent that we were not smart enough to take to the finish line. Why? Because we don't understand the heterogeneity of the disease, and actually we are not smart enough to put this in the context of clinical trials. So when you look at this drug and you separate these patients by p53 mutation or not, you see that those patients that were quote-unquote wild type had a median survival of 32 months. That is significantly better than anything we have seen before. The question is, we never designed the study like that. So I think the next generation of trials really will have to incorporate some of this IPSSM data, some of this molecular data, so we really treat these patients accordingly to their molecular features, instead of this kind of blanket blind studies where we're really not accounting for potential molecular features that really will have a tremendous impact on the behavior of a particular drug. I'm going to focus next in the doublet that I hope, or I think is closer to get to the finish line, but the reality is that I don't know if this is going to be the case. So this is the combination of the HMA azacitidine with BCL2 inhibitor venetoclax. This is actually an old presentation from the 21 ASH meeting. This actually been updated at this meeting. I didn't want to put the slides from the latest version because this embargo issue, and besides there's going to be a nice presentation during the meeting. The data is not very different. So what we saw from this first pass at this combination is that similar to what we had seen in acute myelogenous leukemia, this is actually quite active with an overall response rate that is over 80%, with this combination of marrow CR/HI of around 24%, CR rate of around 35%. That looks better than anything that we have seen before. But remember, the Panther trial had a CR rate of 30%. So we don't really know when you design these clinical trials what will be the CR rate to beat. So that's something very important. This is a complicated slide, but it gives you an idea that the survival of these patients treated with this doublet appears to be better than what you will expect from the randomized 001 trial. It was around 24 months. So that's nice. So my group has studied this and published in two different ways. So the first one was kind of a repetition of this phase 1 trial that you just saw. Maybe we're very anxious in Houston, or we just wanted to have our own experience outside the drug company controlled clinical trial. So this is a study of azacitidine with venetoclax for patients with high-risk disease. It has two phases, has a frontline phase and a relapse refractory phase. Was published in Lancet Hematology last year by Alex Bassinet, who is now one of our faculty members. So what you see here basically is that this combination gives you an overall response rate of around 87%. But very interesting, the marrow CR in this particular study was around 74%. And if you go and apply the new response criteria, this IWG-23 that a lot of people here decided to put together, actually this will eliminate the response rate of the study, which makes a huge impact in terms of how we develop drugs. So we have to also be careful in terms of how we develop this kind of criteria and what intentions do we have when using that kind of tool, because maybe nobody's going to develop a drug anymore for patients with high-risk MDS if we start kind of eliminating this kind of criteria. So you can take my view in terms of this response criteria that was just developed. Anyways, using traditional criteria, a very high rate of response. And then when we look at the survival that is in the blue curve, the red one is for those with HMA-failure disease, we see that in this group of patients that actually had a poor risk characteristics, the median survival had not been reached, again, suggesting that potentially this combination could be maybe better than what we have with the single agent. Now, we move this one step forward. And this, to me, is really fantastic opportunity. That is the development of these so-called total oral therapies for patients with high-risk MDS, right? So you have now the possibility of using an oral hypomethylating agent, this oral decitabine cedazuridine. Maybe in the future this could be with the ASTX030, that's the azacitidine cedazuridine. But we're going to combine it with another compound that is also oral, that is the BCL2 inhibitor venetoclax. So this is just in press in Lancet Hematology. It was presented at the EHA meeting last year. And it's a study of oral combination of these two compounds for patients with high-risk disease. Now, this is interesting because if this is too small probably to see, there are a couple of things that are there of importance. First of all, a quarter of these patients had very complex karyotype. Significant fraction of them had P53 mutated disease. But there is another phenomenon that is starting to emerge, that is the presence of these AXL1 mutations. This is something that we need to start thinking because this may be actually a molecular biomarker of sensitivity to BCL2 inhibition, as you will see in a second. So when we look at the full cohort of patients, the response rate overall is actually over 90%, actually it's close to 95%. So these are like the highest rates of response we have seen at MD Anderson with any other combination, with a CR rate of around 35%. That is similar to the phase 1 trial that Jackie Garcia will present at the ASH meeting. Again, this issue of the marrow CR being maybe an issue that may drop a little bit the fraction of these responses. Interestingly, we achieved complete cytogenetic responses in around half of the patients. You see that 53% of the patients that were informative at baseline achieved that response, and a very high rate of these patients, almost half of them, went into a stem cell transplantation. Indeed, actually, when we look at particular genomic alterations. On the left, you see those with AXL1 mutation on the red curve. Actually, they're doing extremely well. Those with P53, even though they respond to this therapy, they don't seem to actually really benefit in terms of overall survival. And again, a huge fraction of these patients are going into a stem cell transplant, and if they go into transplant, these patients are now maintaining long-lasting survival with the follow-up that we have on the trial. Now, in the future, we will learn about how to do this at the molecular level, whether a P53 mutated patient is a candidate for this therapy or not, maybe understanding why an XL1 mutated patient is sensitive to this therapy. Maybe mutations have nothing to do with it. This is data from Simona Cola in our group, looking at single-cell analysis sequentially on this kind of trials, looking at different type of compartments that predict, for instance, to sensitivity or resistance to venetoclax. Actually, AI could be put together to really analyze this kind of single-cell data and give us an idea of who may be responses or not. Now, this was a nice 5 minutes. The reality is that in the next few weeks, few months, I don't know when, we will hear the results of this Verona trial. This is the ASA with or without venetoclax study that will prove or not whether this combination will become the standard of care for our patients. Moving to targeted approaches, this is actually very interesting to me because a couple of years ago, I was invited to, I think it was Dr. Markovati, to put the favor mutation against the non-favor. And I think Luca beat me in the colloquium, like that happened here, but I was actually wrong because it's like today, it's totally wrong. So who should have won is those in favor of the mutation use of this data when making decisions for patients with myelodysplastic syndrome. And the reality actually, we're starting to gain some traction there, right? IDH2 mutations, IDH1 mutations, MPN1, well, this is AML, but guess what? If you don't order your genomic test, you're gonna be missing that particular entity. And this is something that bothers me, calling diseases just because we treat them in some way. I actually don't agree with this. I think a disease is an entity, not a way to treat, but that may be my personal view. And then you could have situations where maybe this TP53 puts you in a situation where you may want to be more nihilistic in terms of how you approach a therapy for particular patients. So we're gaining a lot of traction there, and this is actually something that people come to MD Anderson basically to be analyzed for. Now let's finish the last 2 minutes into maybe what may be happening in the next few months, depending on what happens with this Verona trial. This is a very important slide by Jacob Kantarian around 20 years ago. I think we published it somewhere, but I don't remember. But this is basically a study where at the beginning of this hypomethylating agent development, we said, well, maybe we don't need to give induction chemotherapy to patients with high-risk MDS because according to this, even in younger patients, the decitabine does as good or as bad, depending on how you look at it, that induction therapy. So actually the field shifted from kind of like AML-like approaches to all hypomethylating agent-based approaches. And maybe, like going back to this, I like the Mittelman joke, maybe we should be like kind of in between. I don't know. This is data from the French group by Dr. Peterlin looking at the CPX drug. You could maybe change this for, I don't know, cladribine, cytarabine, venetoclax, or something like that. But what these investigators are showing actually is that these compounds now, they're actually quite active. We know how to support them. We give them prophylactic antibiotics, antifungals, etc. So this data actually is powerful. And maybe we need to start thinking about resetting this clock back a little bit. And then we're going to hear next about transplant. We've made a lot of progress there. Actually, a large majority of our patients now are referred to transplantation. This is fantastic compared to what we used to do 10, 15 years ago, where the mortality was almost universal and the toxicities were horrible. This is really changing. But we need to go back to this idea of what I call total therapy. And this is a term that I started thinking about a couple of years ago, and it's illustrated by the slide by Dr. Salman in one of the APR studies. This is complicated to look, but if you look at the left on the green line, those are patients that had a response, were transplanted on response, and received maintenance therapy. This is the only group of patients with high-risk features, in this case, a study for P53-mutated disease, that actually had any decent survival more than 11 months. This is what we really need to think. Think about this disease as a continuum, not just giving them some type of complete remission. So we need to really think about the full journey at the molecular sequential level of our patients. So this is actually now creating a little bit of issues in terms of how we make our decisions. This table shows how we approach these patients at MD Anderson. I think if you are young, you should really consider almost universally to go for transplant.
If you are older, whatever that means, this gets a little bit more complicated in terms of, someone said with transplant 75, I don't know if it was in Israel, but the bottom line is that's where this molecular data is really important. So to conclude, I think up to today, December 23, single agent HMA still is the standard of care for patients with high-risk disease. Maybe Verona will really change this paradigm and we'll have a new phase of a combination. I really think that these new classifications, this new molecular data is helping us already actually understand this much, much better, both from the type of therapy selection and the role of transplantation. And we have still a lot of major needs in this disease. For sure, we need new doublets. I don't know what's going to happen if Verona fails. We really need better therapy for p53-mutated disease. We have not touched HMA failure here. We need more of these targeted approaches. We need to redefine this role of chemotherapy in some patients with high-risk disease, and we need to do better at integrating transplant for patients with this disorder. And then I was in a meeting in Madrid, and one of my friends there said, if Verona fails, and this is just for the community, should we just totally abandon these HMAs as our kind of, I don't know what is the proper word, as our kind of platform in terms of next generation phase 3 trials to improve the survival of our patients? I don't know if this is proper or not, but we need to start thinking about what's next if that study fails. And with that, I really want to thank you for this opportunity.